we have Leo, we have Mark, we have Jessy, and we have Nate. And they are going to introduce themselves a little bit more fully after I go through a little bit about what is patient-oriented research. Just to give you an idea of the language and what we're talking about here. First of all, though, before we get going, it's always important to acknowledge that we're on the unceded and ancestral territories of the local Salish peoples. I think it's important, you hear that repeatedly today, but it's important for us to remember that. So what is patient-oriented research? It's not a new thing. There's been a lot of community-based research and participatory action research, terms that are used to describe ways that we get the people that are going to benefit from the research, from health research, into the research process. This is a little bit of a different way of doing things for a lot of researchers, because researchers are used to just sort of designing their research projects and going out and recruiting participants and then just doing their work. We're asking researchers to do things in a different way. Now, the Community-Based Research Center has been doing a lot of this work for quite a long time, so it's not, like I said, it's not something new. It's just kind of new language and a new way of looking at it through the health system, the health research system in Canada. First of all, I have to say that when we talk with the word patient, I want to unpack that a bit, because the word patient is a word that was chosen by Health Canada, by Canadian Institutes for Health Research, to actually describe this particular initiative and why we're doing this work. But when we think about the word patient, I want you to unpack that and to think and replace the word patient with something else that's more meaningful to you. Community member is a good one. One of the things that we often land on here is the idea that the reason why we're bringing people into the research process is because we understand that everybody has their own lived experience that we have to bring to it. And that's the same with gay men as well. So when we define patient, we talk about personal experience, and it can mean anybody who has access to the health system in some meaningful way. It can mean a person who's receiving treatment or about to receive treatment or their caregivers, a lot of different ways that we can describe that. So don't get bogged down too much on the word patient in this. One of the important things about this is that we're asking patients and other people who get involved in the health research world to get involved at a very much higher level of involvement or engagement than they ever have been before. A lot of researchers stop at the inform stage. They just tell people what they found and that's the end of it. But we're asking researchers and patients to get together and collaborate at the higher levels of engagement. But you'll see from this little graph that the higher you go up this ladder of engagement, we see that it costs more and it takes more time. So this is why there had to be a real push from the Canadian Institutes for Health Research, which is the main funder of health research in Canada, to really push this forward and to really say, hey, if we're going to involve people in this work, involve the public, involve patients, then we need to make sure that we give them more time and the money to do it. There's lots of things to consider, and I'm not going to go through all of it. This is just a very brief introduction to patient-oriented research. But we really are thinking of patients as becoming team members. They're becoming a member of the research team. So thinking about this, we are have thought a lot about what researchers need to know in order to do this work. They need to know what level of engagement you're going to have your patient partners take part in your research, what roles they're going to play and when in the research cycle. Lots of things to consider. It's complex, but it's not impossible. And we also have to think about what community members need. And this was Nate's suggestion that we remove the word patient and think of community members, which is exactly what we're talking about today. So we have to think about how can community members get involved in this work? And that's why we're really pleased to have Chad here, who's along with us today, because he has done a lot of this work. So what I'm going to do now is I'm going to ask each of the panel members to introduce themselves. And then we're going to talk a bit more about how we can talk about patient-oriented research and how gay men can help inform the research and then, in turn, improve health systems and health services for us all. Chad, do you want to go first?
Hi. My name is Chad Dickie. I'm Dene First Nations from Fort Nelson, BC, and I'm really thankful to be here on the traditional territory of the Coast Salish people. I live in Victoria. I've been living with HIV for half of my life. I'm involved in community-based research. I'm involved at the national, provincial, and the territorial level with patient-oriented research, the Canadian Medical Association, and other primary care initiatives that are implementing patient and person-centered care. And part of the whole thing around this is how do we get more LGBTQ voices at these tables where new regulations and new policies are being designed, because I'm often the only person of color, the only person of MSM background or with HIV at these tables, and we need more voices to participate so that we really can move things forward. Because what do we want to see our healthcare system look like for people, for MSM in the year 2025 and 2030? Thank you.
Hi everyone, my name is Leo Rutherford. My pronouns are he and him. I'm a queer trans person and I'm a PhD student at the University of Victoria. I'm also one of the BC Support Unit's fellows this year for patient-oriented research, which is a new initiative that they have, which is very exciting. Yeah, I'm very happy to be here and to talk to you all about the importance of including patients and how to engage us in research.
My name is Mark Hull. I'm a physician up at St. Paul's Hospital and at the HIM clinic here in Vancouver. And obviously we do clinical work and a lot of clinical research with many of our partners.
Hi everyone, my name is Josie Dame. I am a very proud Two-Spirit Métis registered nurse. I am an uninvited guest on these lands. My family is from Treaty 1, Treaty 2 territory which is now known in Manitoba as Winnipeg and St. Rose. I am a registered nurse that works at a sexual health clinic downtown in the West End, and I'm currently a second-year master's student at UBC studying the normalization of sexual harassment among self-identified men who have sex with men and within the Two-Spirit community, as well as sexual violence itself.
Hi, good afternoon, everyone. My name is Nathan Lachowsky. I use he, him pronouns. I'm a settler researcher, cis gay man, and I am the research director for Communitybased Research Center. I also work at the University of Victoria as an assistant professor there, trying to do this work.
Great, thank you guys. And so Nate, let's just start with you then. Let's talk a little bit about, you tell us a little about the patient-oriented research that you've been doing, some of the work that you've done in this area, what strategies you've used, and to start with that.
Yeah, thanks, Larry. And thanks to Chad for organizing this panel. So I think for me, thinking a little bit about like who we are, and I'm just interested by a show of hands, how many people have been at Summit before? Okay, maybe let's try the other one. Who is first time here? Okay, nice. So look around and like those people who raise their hands the first time, like find the new people and make a friend. Because this is how we build community, and this is how we build connections that will persist over time and that make our group that is here a real viable partner, for lack of a better term, in terms of research. So to me, I think this is the kind of work that we've been doing and CBRC has been pushing since its inception. And now patient-oriented research has come along as a broader kind of mandate. So for me, what I think about in that sense is that we've been talking about CBR in the HIV world, in gay men's health here, for a number of years. And patient-oriented research is a new strategy for all of health research. So no matter what the issue is, no matter, do you know what I mean, what the population is. So that's partly why it feels a bit icky, probably, to hear some of the words in the language. But to me, what I see it as is an opportunity for us to start actually getting recognition and support for doing the work the way we've been doing it and the way we've been asking to do it for a long time. And so I think that's really cool. It would have been nice if there was a bit more like accolade to the people who actually like whose bodies and lives were on the line to ask for the work to be done that way. But nonetheless, this is where we are. And so what's interesting about this also is that it's a national initiative. So we're talking very much from a kind of local BC context in this sense, but there is a patient-oriented research unit in all of your provinces, wherever you are. And each of them will be a little bit different, but I would say as like one main takeaway is that if we don't connect our communities to that, those strategies, then we won't be around the table. And so I think the action I would put out to all of you as a request is that when you go home is connect with those groups, because they're often the people who clinicians or researchers will go to say, do you have someone who's living with HIV in your network? Do you know a gay man? And maybe they don't ask those questions for those specific groups, but they're asking the connection, or they're being asked to be the connectors between community and the research world. And so if we then show up in those spaces and are like, we're here and very happy to be a partner, then there will be new opportunities for us to be engaged in projects. So I think that's one small thing that everyone can do. The other thing is that many of these units across the country also have resources. They have resources to support people to spend their time engaging in research so that it's not just something that people need to volunteer for. Some of them have resources for small startup projects and consultations. They have access to meeting space, doing all kinds of different things. And that can be quite helpful because it can be a kind of more neutral space. And so I would really just encourage people to look at this as an opportunity that can be assistive in doing the work the way we want to do that. For me, as a person who now has a job at a university, I think about the fact that I share some aspects of my identity with some parts of the community, and increasingly I'm aware of how little overlap I have with some of the folks that we work with. And that really is related to the vast amounts of privilege that I have based on my religious upbringing, on my race, on my language, on my credentials, on so on and so forth. And so for me, part of trying to do this work well is thinking about what are the ways in which we can bring the right people around the table so that we actually have true representation and voice in the process. And so I think that's an important part of this work. I think the other piece I would just say, just to push back on the piece around time and money, is that all good work takes time. And so I would change that scale to say that it's not about the fact that it takes more time, it just means the work is better. And on the resource side, I would say it's about spending resources differently. And so as someone who trained in many different environments as an academic, we get taught that there's ways in which we're supposed to spend our money wisely. And I think thinking about patient-oriented research in a way that says, actually investing in the people who this research is really about and for is fundamentally the best way we can spend that money, and making an argument for that. So I'm not going to talk too much about projects, as I think examples of that can come up. But I think some of the ways that we do this are really thinking about the fact that I would say that we start at the top of that pyramid in terms of really trying to find co-leads. And that this really is about a shared leadership kind of approach. And that fundamentally we have to start by defining the issues. And then what I see my job as, and for those of you who are in similar kinds of positions, as someone I was talking with, one of the folks from the island this morning, they were like, I need a yes man and I need a money man. And I was like, he also needed some other things, but I was like, those are the two things that I can help you on. One of which is telling you yes, this can happen, and two of which is I can figure out how to talk to the funders and get money to do this project. So think about what skills you have to bring to the table in this work and leverage that. The other thing I would say for those who aren't in academic positions or who aren't clinicians or providers is that ask those people to help you. I've realized how soul-sucking parts of our jobs can be, and when people come and ask you to do good, important work, it's really actually quite a refreshing invitation. And so I think sometimes there is quite a barrier between those of us in universities and the rest of the community. And so what I would say is look for those opportunities when there are public events or when there are engagements, or if you're really bold, like many of you are in the room, just cold call people. It's amazing how little we actually get contacted from the outside, or at least I do. And then the other thing I would say is that we need to really think about mentoring the next generation. I think that's the importance of young people. I think in the talks this morning were about the focus of children and the gifts that children bring. I think a lot about the fact that I'm not a young gay man anymore, and so I see my role as starting to help and craft a new generation. Yeah, sorry for other people who are of other generations. I'm not the youngest, is maybe what I should have said. But that I think we all have a role in mentorship because we are doing something differently and we've learned a lot, and so we need to find ways to share those things. So.
Great, thanks, Nate. And Chad, a couple things that Nate said that was really interesting, bringing people to the table. And you are certainly one of those people that's come to sit at the table and demanded a spot. So can you tell us a bit more about some of that? Sorry.
Yeah. So these are just some of my engagements that I'm involved with as of October 2019.
If you want, just this.
So, so I'm the board chair of AVI, but also I'm involved in primary care network development on the South Island. I'm a member of the Canadian Medical Association Patient Voice Committee, and I'm also a contributor to the Vancouver Foundation System Change Grant Review Committee. And we have last year, the Vancouver Foundation granted over $16 million to community funds, community organizations across the province. And I'm the only person, MSM person, First Nations person living on disability benefits at those tables. And we really need voices to come to the forefront. with your experience, with your lived experience, with your challenges, with your opportunities, with what you've learned and what you've experienced in the healthcare system, as the healthcare system in BC evolves to primary care networks and patient medical homes. Because one of the things around that is we need to have voices at the oversight tables. We need to have input on what works and what doesn't work. Because lots of times we also need to start creating some evidence around the challenges that we are facing within healthcare access, accessibility to care that is appropriate for our needs and our population and our communities. The one thing that I really want to hear more about from you is, what do you think our healthcare system in BC should look like for men who have sex with men, the LGBTQ two-spirit population in the next 5, 10, 15 years? Because BC is rolling out primary care networks right now. They're adding new healthcare things to the ecosystem, like urgent primary care centers. And these have steering committees, these have oversight committees, these have opportunities for your input to what matters to you and our community, and how those policies are going to be implemented right up to the top at the Ministry of Health level. But also, we're really trying to push things with the federal government too, through the Canadian Medical Association. So there are opportunities there for your voices to help shape what healthcare in BC will look like, and what healthcare will be for Canadians across the country. The one thing that I'm happy to have two providers here, Dr. Mark Hull from St. Paul's Hospital and registered nurse Josie Dame from HIM. And because, so the thing around that is, what does longitudinal, coordinated, wraparound, and respectful care look like for us that have to use the health care system, that may have issues that pop up, or have chronic conditions? What is going to be respectful care, and how is that going to be actuated? How is that going to be, how are your voices going to contribute to that? That's what I'd like to hear.
Yeah, great. Why don't we just go with that question?
Yeah, sure. So thank you for both of that. I think when we're talking about, it's a common conversation in nursing and everywhere, is we're always talking about finding a seat at the table. And I have a huge issue with finding a seat at the table and what that means, and ensuring that that person, if we do have a seat at the table, isn't tokenized. And I think as researchers, or a lot of us as researchers, we shouldn't be at that table. That table should just be community members, and we should be supporting that table, but we shouldn't be at the table. The community should be making up that table. So we're always talking about finding a seat for the community member, but what are we talking about? We should be just having a table full of community members and stepping away from that image of policymakers all at the table and having one tokenized person speaking for everybody. So I have a huge issue, because it happens throughout my entire undergrad and throughout my entire work so far, is always that singular focus. And how can we expect to gain information when we're always just siloing and segregating a specific person to speak on behalf of everybody? So it's like, how can we switch our view as researchers to be a lot broader and a lot bigger, and how can we switch that view from policymakers to ensure that we're making policies in a quick fashion, but also ensuring that they're completely community created, driven, and beyond that. So that was my feedback. And then, yeah. Sorry.
The microphones. Yeah, so I was just going to say I came to the realm of patient-oriented research because I believe in community-based research and research that is by and for communities, kind of as what Jessy was saying. And if you don't know, it's kind of hard to get funding to do community-based research. And thankfully, there is funding through the patient-oriented research, which is amazing. And it was the first grant I applied to as a PhD student. And I wanted to work on that grant and started that project because as a member of the trans community, I realized that historically, all of the research about us was on us. It was cisgender people conducting research on trans communities and about us without including us in any way, and often getting it wrong because they haven't included patients and the data that they analyze doesn't make sense or really fit with a lot of people's experiences. So for me, I really just value research that is conducted by us, with all of us at the table. And I'm in a unique position as both a patient, a trans person, and as a PhD student who will eventually hopefully have a PhD and be able to like get my own people at the table. But I realize that that is a unique experience. And so yeah, just to kind of echo, like if we can be bringing people up from the margins and bringing them into spaces and putting their voices in the spotlight and centering those experiences, I think not only will people benefit, but research can be more nuanced and more specific and more helpful for everyone to gather like correct data about the populations that you're interested in, as well as giving something back to the community. So yeah, there's a lot to be said, I think, for including patient voices.
I'll use this one. I think I agree very much with those statements, and I feel if I look back now that Nathan has aged me so dramatically in terms of looking back, and I know Daryl Tan is here in the audience, and we started very similarly in terms of looking at things, is I feel we have to move away from this notion of tokenism, because I think it's pointless. Like, we don't want to have one person who's supposed to speak for a vast community which is very diverse and think, oh, you're going to tell us everything that we need to know. And I think we actually have to ask ourselves, what is the goal of our research and what is the goal of our service delivery? Because I've seen too many times when I was starting as a junior person that somebody would be like, oh, this is the program that we want, let's just design the program. And then we're like, oh, nobody's using this program, what's going on? And we realized we had zero consultation with the people it was actually for. And you're like, what do you think was going to happen? Like, we have to make sure that it's, as you said, and you can't do something without knowing who it's for, and that means listening to the voices of people who you're trying to design a program for. I think we have to have it not as a pyramid, but as a circle of realizing who we're involving, like asking the questions. Are we using the right language? Are people going to use the service that we want to look at? And Vancouver has had CBRC for many years. It changed my vision of what research actually looked like. And I can't imagine designing a project now where you don't start by going out and involving people that you want to engage at day one of the program. You can't come at the end of your program and say, oh, now consult on our program. They have to be at the seat at the very beginning, informing what you're going to do. And I think the language using patient-based research sometimes is a little bit tricky because people don't identify as a patient, but we should identify as communities and say, what as a community do we want to see happen?
Yeah, and another thing too, as I mentioned, the BC is moving to primary care networks and patient medical homes, putting the patient at the center of their care. One thing though, the patient has to have some capacity. We have to improve health literacy. We have to have them understand research. We have to have them be knowledgeable about the system approach that is entrenched in the healthcare system. And also, how are we going to change some of those system change and culture change approaches that are embedded in the current healthcare system as we evolve, as we move towards PCNs, patient care networks. Those are opportunities for patient-oriented research. Those are opportunities for research, clinical workflow research, practice research for the clinician side, and including clinicians and providers within the SPOR framework. I think one of the things too is we have to look at having voices of diverse voices to help with the primary care implementation to participate in the governance and healthcare quality oversight. Because what the care that they receive in the Lower Mainland might be quite different from the experience of an LGBTQ person in Northern BC. So we have to understand how we're going to, what are the structural barriers? What are some of the challenges that they have with supports and access to health culture that supports and enforces that enforces or reinforces inequalities and enables inequities based on whether it's transphobia, whether it's homophobia, whether it's heterosexism, racism, and also socioeconomic disparities. I think one of the things around volunteering to these committees, it gives you the opportunity, as I mentioned, through the Patient Voices Network, that's your first access to accessing different opportunities. 4 main points with being a patient voice: you have the opportunity to make a difference, you're supporting participation, you're network building, which is very important, but also if you're a student or changing careers, there's a great opportunity to resume build. I've sat with people at the, assistant deputy ministers from the Ministry of Health. I sit with doctors, emergency doctors, and those sorts of things are very valuable to me because then I can see those doctors and practitioners as human beings. That little bit of the veil gets taken off my eyes. They're no longer on this pedestal because they actually start talking to me about some of their healthcare challenges. And that really was a shock to me that they'd do that. And it makes me feel that if I can do this, I want all of you others to feel that you can do it too. Because I say that, I keep trying to volunteer myself out of a position because I'd be very happy to help anybody else to do anything that they want towards strategies for patient-oriented research or primary care network implementation.
I just wanted to point out that Chad has mentioned the Patient Voices Network. Is anyone here a member of Patient Voices Network? No. Patient Voices Network is an organization that's funded through the Ministry of Health, through the government of BC, more or less, to help improve the quality and safety of patient experiences in the healthcare system in BC. And it's a group of volunteers who get together to help basically to improve quality, a lot of quality improvement type work. They've recently reached out and started getting involved more in health research itself, sort of designing the interventions, not just delivering them. So I think it's important that we note that PVN is a great group of people. I think they have 3,000 members. 75% of them are white women over the age of 65, and then most of them are retired healthcare workers. I don't know if I've ever come across another gay man volunteering for any of this work or being a part of any of this work. So that's why we always ask Chad for help when we need it. Great. And one of the things I wanted to point out is Mark was saying that we're designing health services, we're designing interventions for people. What sort of treatment are you going to offer someone? And that's a really big question. If you don't have the knowledge user involved in that, how do you actually create the knowledge? And Mark, you're a physician, so you're actually one of the knowledge users, and that's one thing that I should have mentioned earlier, that under this strategy for patient-oriented research, that I'll talk a bit about more afterwards, we include patients as part of the research team, but we also want to include clinicians, so doctors and nurses, to be part of the team as well, because they're the ones that are going to have to deliver the intervention that whatever's designed. So it's important to note that. And the one person that should be at this panel that isn't is a policymaker, someone who decides what money is going to be spent on what services and where. And if anyone was at the transgender reproductive health workshop earlier, you realize that those services just aren't out there. So we need to have that person at the table as well. Do you guys have any comments about that?
I guess just briefly, I mean, we always talk about policymakers, and I think there are a lot less of them than we realize in terms of the ones who are really in positions of power to make difference. And so I think that it's important that we figure out who they are in our communities and then figure out how we get connected to them. That would be my strategic.
I don't think you can get
I support that, as well as I would love to see the microscope switch around onto the policymakers, and let's investigate them a little bit and the decisions that are being made and why the decisions are being made.
And one thing, we have to be at those tables to do that. Mm-hmm. Those voices have to be there to pose those questions, because a lot of it is that system change approach, which you don't realize that you're nudging change. Mm-hmm. And one of the things is it's around nudging change and being iterative, because it's always around the system doesn't know what it doesn't know. And if we have voices there, then we can say, hey, that intervention is not going to work. But that approach is disrespectful, or that approach has to be tweaked this way, because it's really around our voices collectively moving change towards something that's going to be better for probably not my generation, but the next generation, and I'm okay with that.
I think from my experience, they're a very conservative and opaque group of people, these policymakers. And you have to be able to show every single time you're having that conversation, what is the goal of what you're trying to achieve? And that means you need to, maybe you consider me a knowledge user, but I consider the community to be the ultimate end user of any service that we deliver. So you have to have that conversation piece where you're like, what are we trying to achieve? Who are we trying to achieve it for? And every time you have a conversation with somebody, who you consider a policymaker, to lay out those points again and again and again, because it's very incremental in terms of how they shift their thinking, in terms of saying, oh, actually, I understand finally what you're trying to tell me. If you present a program that's 90 degrees opposite of where you are right now, it's never really going to get that way until you can build the bridges to show what you're trying to achieve.
I was going to say, getting people to the table and getting people to share their voices through a patients network or other means is often a challenge because it is volunteer-based. Yep. And a lot of people in our communities can't afford to take time away to volunteer, or if they do have any time, they just need to be spending it getting revenue because they can't otherwise live their lives. And so I think it's really important to consider how we can either give money to people in community or give them something else in exchange for their time, whether it's, provide babysitting or bus passes or a meal, anything that we can do to make spaces more accessible for people to show up who have diverse voices or other experiences. One thing that I've been really lucky to experience is having, I submitted a grant application that was with community members as patients, and thankfully there were funds that were able to be provided to them just to participate in the grant process, which was really exciting. So those resources are out there, as well as resources to help people just get to the table.
Now, one of the things that I'd like to do now is as the panel is talking and discussing this, if anyone has any questions, we do have a mic up here, and I think it's turned on. Or it will be soon. Do feel free to get up and ask questions while we're going through this discussion, because we want it to be a bit more interactive now that we've warmed up a bit. And if I don't see you standing there, throw a shoe at me or something, and then we'll get you going. So if anyone has any questions, feel free to come on up and ask. Jesse, do you want it to?
No, that's okay. I mean, I guess speaking to kind of what Mark was just saying, and just I feel as a new junior researcher and student, it was a bit of a smack in the face and shock to realize how slow things move and how small we have to make these moves. I kind of expected to just go in there and blow it up, and it made me feel I lost a lot of faith kind of in the academy, and questioned a lot of why are we doing this if it's going to take this long? What are we doing? And I had a conversation with one of the professors at UBC who felt very much the same, but also was just we have to be the pebble in the pond and see those ripples, and eventually those ripples will get to the other side. It's still very hard for me to digest, but I understand that we can't go to that. I don't know why in my mind, but I understand that we can't, I guess, in some way. But it's really hard to not lose faith in it sometimes, but I'll be that pebble anytime.
You're the rudder steering the ship. That's what my mentor once told me in terms of things.
Okay,
if you want to shift the system, you have to accept that you're doing a little incremental change up here, and eventually the whole system shifts. But it's very frustrating, and you bang your head against a rock until you eventually why am I doing this?
So we have a brave person who wants to ask the first question. Do you want to go ahead?
I do. Thanks. Hi, everyone. My name is Robert. I have a question, trying to get to the point as quickly as possible, which also is going to come off as very cynical. But my question is coming from, as an American who recently moved to Ontario, and also as a registered nurse, previously was a case manager for a home care agency. I've been very disappointed in my access to care, the levels that I've had to fight and advocate to get the care that I need, and seeing, working in the community and seeing the struggles of other folks. So my question, and something that I've been giving a lot of thought to both personally and professionally, is how do we, what's the incentive in the public healthcare system for service providers and for institutions to take on the research that you're doing, as community informed as you hope it to be, to really create change? And just an example of, to explain myself further, I know previously, before I left home care in the States, which was following suit of the hospitals, which there were certain things that had to be publicly reported. So the public has a choice about which hospitals and also which home care agencies they would pick. The insurance that I had a concierge service that would call me and say, how's your doctor? Are they gay friendly? Do you need a new one? So there's much more power and much more reason for a doctor or nurse or an institution to, involve all these evidence-based practice. So I'm just curious as your thoughts how we do that in the Canadian context.
Is that directed to anyone in particular or just the whole panel?
Anyone who
Okay.
has any insight?
Thank you for that. I mean, I think one example I think about has been around PrEP, and I mean, there's lots of people who've been involved in that on this panel. And I do think that often the role of health economics and finances are incredibly powerful in our public system because there is a very clear message that there's a fixed amount of resources and we need to be more efficient or find ways to save money. So I think the more that we can try to frame things, and it's kind of the thing of like having the conversation that they need you to have, if that makes sense. But I think that is one of the languages that is effective, I guess, in terms of actually like making people interested in what you have to say, if you can demonstrate that there's a cost impact around that. I think we still struggle quite a bit to understand the cost benefit of public health work because it's not direct and it's not immediate. But I think that's one piece. The piece on public transparency is quite interesting. I think that feels like almost like a cultural piece in Canada. I think back to when I was in Ontario around standardized education tests, and there was a lot of flack around publishing results of what schools were doing better or worse or on that. And I mean, it's a big issue in terms of lots of things, but yeah, I don't know if we have a really strong culture around public accountability. So I don't have anything else on that. Those are my...
Yeah, I just wanted to kind of add as well that I think at the end of the day, it comes down to what people value. And I think in our society, we are starting to see a really slow shift away from doctors and healthcare systems thinking that they have all the information, to kind of like a slow shift to realizing that patients' experiences are valid and are their own source of knowledge. And so I think in order to really create change around that, it's just about advocating for the fact that we should be valuing something different than maybe what doctors have historically valued as knowledge within the institutions. And then when people realize that the best place to get knowledge is from people with lived experience, I think then we'll see more uptake of this kind of research.
And also, I think one of the things too is that move away from the biomedical model of care to more of a wellness approach. And I think one of the things that it does become driven by community. It does, if you're trying to put patients at the center of their care, that does mean a shift within the healthcare system approach. And I think finding opportunities to develop research opportunities and finding evidence that validates your concerns is an approach that is an opportunity that exists now through SPOR, through the CIHR and other initiatives, and it's something around improving and growing capacity for the patients, and the community to drive change.
I think, like, going off kind of what they're saying is like value, especially I think in academy and in the healthcare, we are so focused on publication, and that's the incentive in a lot of things that we do is publications and getting published. And how do we switch that view from a focus on publications to experiences and like getting those out there rather than an article that none of our patients are going to read? So it's how do we switch that? I don't know, but I'm experiencing that a lot about the importance of publications, and the only way you can get published is by being published, basically. So it's like an ever-ending circle for new research, as well as what does that matter to the patient sometimes. So switching that value again.
I don't think it doesn't. I think that's the crux of the matter is it shouldn't be research for research's sake. And that's what I think you see so many times when you encounter university-based researchers. I don't know, ask people in the audience what their opinions are, but it drives me crazy when people are like, oh, look at my beautiful paper. And you're like, but who cares? Like, what does that really mean? Like, it's not actually achieve anything to improve anybody's life. Like, what is our goal here? Our goal has to be the healthcare system working for people who are accessing the healthcare system. If your research paper doesn't help with that, then it doesn't help me.
I just want to add one other quick thing around strategy. So one thing that CBRC has tried, in BC we created a a health authority's report card. And it was on a limited number of metrics, but I think part of the idea behind that was twofold. One of which is like communicating very succinctly to the public about where each health authority was at in terms of some basic statistics. The other of which was as a tool is creating something where there's a natural comparison that gets done. And I think that organizations that are responsible for health do care about their public image. And so I think there is a tool to be leveraged in terms of competition to some extent on that, that nobody wants to be seen as the worst or as doing the poorest. And so I do think we could lean in a little bit more to that. And I know the National Advance Alliance is also working on similar kinds of pieces. So I think, yeah, so that might be one other strategy, is a bit of like trying to build that public awareness and lean into competition around having people do better, or organizations do better.
Just remember, it can take 17 years, up to 17 years for research to make it into practice. And so what you're talking about too is the knowledge to action gap. We generate lots of knowledge, but we don't have a mechanism in place to make that knowledge available to the people who need it. And that's the clinicians want to provide the best service they can for you, but they don't necessarily know what that is. So that's why we need to build these bridges. We have another question.
Actually, I have a comment and a question. I'm Alan Lee. I'm a clinician, community-based researcher, community member, immigrant, racialized gay man from Toronto, Ontario. And I guess I appreciate the panel and having this focus of discussion. I just kind of trying to maybe push that into a slightly different direction, because I know that between CBRC and a lot of the community-based research I'm connected to in Ontario, there's not the lack of wise practices available, right? So the question is not about, why we're not doing community-oriented, accountable research. It's about why it doesn't get to become the norm and the mainstream culture of the research field. So I'd like to raise a couple of questions and comment. One is, I think, when we want to listen to patient voices and MSM voices or people with HIV voices, I guess the traditional way is to look at, how do we build the community's capacity so that they could be equal partners at the policy table? And I think that we need a paradigm shift about that. I think the policymakers needs to change the way they listen to the community, because whatever ways and the same way about the point you bring up about publication, right? So, as long as the culture doesn't change, no matter whatever work we do, it will still fall into deaf ears. So my question is also about how do we change the funding culture and the CIHR way of doing things and having that filter down? Because we divided it to academic researchers and knowledge users. So as long as the paradigm is about the clinicians and the researchers are generating knowledge for the community to use, I think that's just fundamentally wrong and flawed. So until we switch that around, nothing else is going to happen, right? And I guess the other question I want to pose is, sometimes when some of us get to the policy table and have some access to policymakers, we often forgot the rest of the communities. And as our community become more marginalized and more diverse, how do we ensure that we don't become the power broker and forgot the people who really doesn't have a voice? So thank you.
I think one of the things you mentioned about building capacity, it's through opportunities like the Patient Voices Network in BC. I'm not sure what they have in Ontario, but they have something similar to that. And it's around quality improvement approach to healthcare. And that's an opportunity there. They offer workshops, free workshops. They offer things around system change, how to be a patient advocate, all these sorts of things that can help develop those skills and opportunities to participate at any level you feel comfortable. I think one of the things you do mention too about having to change how we listen, that's definitely part of the system change approach to how the healthcare system, but also the communication component around the system change. It's really around nudging change. We can't look at revolution it has to be evolution as opposed to revolution, and it really has to be incremental. But it has to be you have to be at the table. You have to be able to call some of these policies and contribute to policy development. And it has to be peer-driven, and it also has to be community-driven. And then one of the big things is collaborating. You have to collaborate with community members, different agencies, like-minded opportunities, social service agencies, allied health professionals, community and nonprofits. All these things are opportunities because they've got expertise in these areas of lived experience. Those are where we have to include those pieces because there's a wealth of knowledge that is not being used to the ability that it could be, is my belief.
You asked a lot of good questions. I wanted to speak to the question kind of about why is community-based research not the norm? And I think we have to realize that the academy is something that was built by cisgender, heterosexual, white colonizers. And we still live in that system, and that has trickled down through everything that we have all done. And we have participated in it, and there are some voices who still are not really welcome. And so if those people can't get access to this institution that grants people power and privilege and the ability to do this kind of work, then it's not going to get done. So I think there's like a really big systemic issue that's at play for why people aren't able to conduct this kind of research, and I don't know how to fix that. But I think if anyone knows how to bring more people into the academy or has the capacity to like take on students who are more marginalized or people who have had less good experiences in academic context, if you have the capacity to bring on a student like that and mentor them and help them to do this kind of research, that's amazing. Like that's the only way I can think that in the long run, research is really gonna start to change and community-based research will be the norm.
Yeah, and I think, Leo, you hit the nail right on the head there, is like we're trying to work within a system that does not support us in any way. We're working within a Western English education system that like is extremely limited for even trying to describe ourselves as human beings, especially within, for example, the two-spirit world and the ambiguity that comes with that. That's not language that we can even use in English. Like there's no way to fully describe it. So within the Western education system, it's very limiting and extremely problematic because we're trying to explain ourselves, but we don't have the right words or ability to, so then we're not seen as valid. We can't define ourselves, and we don't want to define ourselves. Well, for me, I don't want to define myself, and I shouldn't have to define myself to access service or to publish something or anything, but in our current state, we are forced to define ourselves to be accepted, and then it just continues and perpetuates like discrimination and limitations, which is extremely problematic. So how do we challenge the system that we're in? I mean, having conversations like this is the number one, I guess, and then building capacity, like you said at the table, is, I said earlier about tokenization, getting to that table, if that's the way that we need to take it, is great, but once you get to that table, you need to ensure, or we all need to ensure that when we're at that table, we have a crap ton of privilege, a crap ton of power, so what are we doing with that, and how are we ensuring that we're not speaking on behalf of, we're speaking with? So it's really like switching your mind to continuously check as researchers our place of power and privilege and what we're doing to influence the community and what the community is doing to influence the policy, which should be the main focus. It shouldn't be about what our influence is, it should be what their influence is. Thank you.
Yeah, just a few, thanks Alan. I think again, like such great questions and points. I thought a lot about this, like why isn't our CBR work taken up? Like we feel good about it, the community feels good about it, like it just seems natural, but it doesn't happen. One thing I've reflected on a little bit is needing to involve policymakers and those decision makers from the start. And I think sometimes we're creating solutions for problems they don't see or problems they don't want to address right now. And so I think there is also a timing to the work. And so that to me is kind of related to the second part of my reflection a bit, which is that fundamentally, like, we need to be political in this. And those of us that have more secure positions, like academics, like medical health officers, need to be political and need to realize that we're not going to get fired, we're not going to actually get reprimanded, and the communities we often work with, or those agencies, often have a much greater loss potential if they stand up and do that work. And so I think, and I know you do that, and so I think we need more of that, and we need to encourage each other to do that and to like stick our necks out, because there are many of us who have much more secure positions. And the last thing I would say also is that I think that there's something that we need to start. I mean, I know that this summit was rooted in gay men's health originally, and it is like working over time to try and become more and more inclusive. And I think that that's important also for this exact reason as well, is that the more that we subdivide ourselves and partition ourselves off, the more we make ourselves a small niche that can be ignored. And I think we need to work really hard to connect across what might be seen as major differences, which is really hard work to do. But I think that there is something important for us in terms of being more unified, in terms of here is something that would work for multiple communities. Because I think often it's difficult for a policymaker who might hear 7 solutions to a similar issue and then just aren't able to do anything. And so I think we have to do that. I think we have to do that work ourselves, sadly, to get to that point. So I don't know.
Great. Now we have another question.
Hi. So I wanted to ask if you could share your thoughts on how to navigate the tension between helping build healthcare systems that work for and by people without putting the responsibility on the individual people for solving those problems. And if you could comment on what role research might play in helping address that tension.
All right, who wants to tackle that one?
Great question.
I think it is going to be, as we said before, incremental, but I think it goes in both directions. The switch in how CIHR set up some of their funding and the switch to looking at knowledge users and having a more emphasis on community voice, I know from my point of view is something that I think we've seen embraced by a lot of our community of researchers in terms of realizing you have to involve the community at very early stages, and by doing that, then you can look at the service delivery. But it does ultimately become very slow in terms of translating into what does the actual healthcare system do at the end of the day, and it does put a lot of pressure on people to self-advocate, which, as Nate has said, often requires you to have some degree of privilege to be able to do that. So unfortunately, I think it's going to be a pretty slow process before we have a really reflexive health system that invites input from communities, especially marginalized communities, to shift how we deliver our services.
And I think one of the things is the healthcare system that works for people. How is that going to be implemented? The province of BC is moving ahead with putting the patients at the center of their care within the healthcare system. Person-centered, patient-centered care. However, on the number of engagements that I'm involved with, we really want more patient voices. We really want community voices, peer voices, and helping develop that capacity for them to engage is one of the pieces that's missing out of this whole implementation and rollout of this new primary care network approach. And we're advocating for there has to be some changes at the level within medical schools on how providers communicate and work and approach diverse communities and their needs, but also the community itself. We went back. Larry had mentioned the IAP2 spectrum. The International Association of Public Participation Spectrum. The lowest is informed, then you've got, do you have a slide on that one?
Let's go back to that.
Yeah.
Let's see if I can get it.
Yeah, there. So we're really looking at community voice leading, being empowered to contribute at the highest levels to implement change, to help guide change in the direction that is going to be meaningful for population health, and encouraging that, and through that participation is an opportunity to model the way and how to make change that is meaningful for the population that you're part of and the community that you're part of. I think part of it is knowing that there's resources out there and knowing that these opportunities, as Mark had mentioned before, it's really about iterative change. It's reflective learning as we go step by step, and it's not going to be fast, unfortunately, but it is something that we need voices there to participate so that it is meaningful for the population, and population health approach as we move forward with different changes and implementations that are happening.
And to go back to kind of what I was kind of speaking to before about the community involvement and having the table of community members, I think that is extremely important to ensure that the community is involved, but then the responsibility is off them so that we are doing the follow-up. So if not having the researcher at the table, but at the table behind, we can take notes, can like support in any way possible, but take the responsibility onto us as the researchers instead of putting it on the community, but ensuring that we facilitate the conversation, that we hear exactly what the community wants. I think that Nathan kind of responded to in the last question was just to notice that research is a political and public service, and that's something that I think we continuously forget and needs to really be repeated again and again so that we all understand where we're at and what we're doing.
I just wanted to make a few comments, Aurelia, about the tension piece. And I think, so we often talk about building capacity in community to be good advocates, right? And I think we've all of us have probably heard a lot about that. And we have programs to support that kind of work, but I think there's also a piece around we need to turn that around to also think about how do we build capacity in people who are going to be the policymakers, who are going to be the policy analysts, who are going to be the researchers, about hearing and doing something with that as opposed to just smiling through that meeting. And so I think there is a bunch of work to be done around humility and history. So I think it's important that that we are teaching students about the histories of what have happened over time, particularly from the institutions of which they're going to be a part of, right? And so as an epidemiologist, I think when I try to teach my students is talking through some of those things, right? And I think all of us who are in various kinds of healthcare roles know that our institutions have been a part of colonization and have harmed not just Indigenous people, but lots of other communities as well. And so I think part of that is that I think the only way in which we can take the full burden off of the community is that if we try to emphasize that humility and historical context within the folks that are in greater power.
Thank you. We have about 5 minutes left, so we'll take 2 more questions and then that'll be it. Quick questions, hopefully?
Yeah, quick question. I apologize for folks not from BC. This is kind of BC-centric, I guess, but my question is, you mentioned primary care reform in BC, which is well underway. I'm wondering if you had any kind of specific examples of how opportunities might arrive within primary care reform to improve care for GBMSM or for queer people more generally.
Development of Transcare BC. That's something.
Yeah, that's BC specific though.
Yeah. Okay. Yeah, it's fine.
Well, I can say actually the primary care network that's being developed through the Academic Health Science Network, which is the parent organization where I work, does include patient partners in the development of their work, and they're developing these models that Chad's been talking about. So that work is being done. It's just hasn't reached the point yet where it's advanced past the beginning phases of building the relationships.
I guess the only thing I think just as a key question for me around this often is do we want specialized services or do we want services that work for everybody? That's I think kind of a tension that I do think, because we kind of sometimes want both, and that's what we say sometimes is we want our gay men's health centers, so we want our queer health centers, but then we also want our GP to be able to do all the things that we want them to do. And so there's some work I think we need to have some conversations about which, I don't know. It's not an answer, but.
Now, let's just take the last question, please.
Right, so how do we, again, this is Vancouver, BC-centric, so how do we do all that? There's things already in stream that are happening, such as the move of St. Paul's Hospital, right? And then you're talking about this initiative of listening, and you want our voices heard, or are they being heard, or how can we have impact when a lot of people in the West End are concerned about how that move is going to impact them in terms of how services will be moved when St. Paul moves to another community, right? So the question, I guess, is, can we, voices in the wilderness, how impactful are they? Or do we have an opportunity to do more proactive advocacy around organizing community input that will be heard?
The primary care networks, the model is to have 4 or 5 practices working together in an integrated approach for their panel of patients, and that'll be a wraparound approach. And the one thing around that is it'll include allied health providers as well. It'll include other providers that are part of the that are aligned with the panel's needs for the patient experience. And it's around that coordination and longitudinal approach to care. The move from St. Paul's Hospital over to the place by the train station is going to happen. It's in the works. But the PCNs will still be within the West End area, the downtown area. So they'll have the coordinated longitudinal approach to care. And that's one of the things that we're looking at, the province is looking at. So you're not going to be losing services, but you'll have the move of St. Paul's Hospital to where it's going to be is going to be much closer towards the downtown east side, the higher use of the emergency departments and things like that. So one of the things around strategies for patient-oriented research too is getting the right care at the right time at the right place. And that hopefully will reduce cost for the as well. But also part of it is really to ensure that we try to achieve what they call the IHI triple aim, which is improved patient experience, improved outcomes of the population health outcomes, and the value of the care economically. But also there's a fourth. They've also got the fourth, what they call it, the quadruple aim, which values the experience of the providers. Because I always say too, if I have a happy doctor, I'm probably going to get better care. Happy doctor, better care. So I'm very much advocating for that. That's the expertise and the benefits that the doctors and the professionals, health professionals, bring to the table, and how can we maximize that for them as well as for our care as well.
And just before we finish up here, I just wanted to point out, we talked a lot about the support unit and the strategy for patient-oriented research. And thanks, Chad, for bringing that up again. And Nate, thank you for promoting the support unit. I did want to point out this is a national initiative in every province in Canada. It's throughout all the regions in BC. We do provide a lot of very practical services to researchers and to patient partners who want to get involved in this, and we're reaching out to clinicians and policymakers as well. Lots of things that I do on a day-to-day basis to help make this work happen on the research level. And we have a website, and you can go to our website if you want to find out more. I certainly invite you to do that. We do a lot of things. We have conferences. We have a conference coming up. We have workshops. Our conference is actually coming up in November. Unfortunately, it's now full, but if you want to get on a waiting list, you can. I do invite anyone who wants to learn more about it. I do have some information about the BC Support Unit up here. So in the last, do you have 10 seconds for final reflections before we end off?
Thanks for coming, and I think create your local networks, because I think this is such a geographically based thing.
And I think the biggest thing that we have to compete against right now, especially in a Western healthcare system, is time, and allowing the time for people to do that self-reflection and identify those biases and then grow from them. And we unfortunately don't have a system that supports that, so how can we switch that? Thank you.
I think for me it's a question of building close relationships with community partners and advocating together. You can only move things together if you have partners in that sense.
Yeah, I guess we're all doing a little 10-second thing.
Yeah.
Okay. I don't really know what to say. I think that research that is done by and for people who have lived experience is honestly just the best way to go about doing research that is ethical and also that yields results that are useful for that community. So if that's something that you value, hopefully eventually you'll be doing that kind of work.
And finally, Chad.
Local context matters. It's where you're at, your experience, lived experience matters. Mine is different from yours. Your voice is just as valuable, maybe more valuable, in the discussion. So I really appreciate you taking your time to join us today, and thank my fellow panelists and Larry for showing up. Thank you very much.
And thank you, Chad, for organizing this. Great. Thanks very much, everybody.
For 15 minutes. You're now on break.